as you all step into your clinical practicum, one of the most complex challenges you're going to face is navigating the landscape of trauma. So today, we're going to build a clinical framework that'll really help you understand its profound and, its very varied impact on your clients.
So, this is a question that you are going to see again and again, I promise you. You'll have two clients who have been through remarkably similar traumatic events, yet one is somehow on a path toward post-traumatic growth, while the other is just deeply struggling. So why is that? Well, the answer is never simple, because the event itself is really only the beginning of the story.
And this is the crucial point right here. We absolutely have to look beyond the event itself. See, trauma isn't the entire picture. It's this powerful force, sure, but it's filtered through a person's unique psychology, their identity, their place in society, and even their job.
So, to make sense of all this, today's explainer is going to give you a framework for understanding these variables. We'll structure it into 5 key areas. We're going to start with the diagnosis itself. Then we'll move into the internal world of cognition, zoom out to those external forces, take a look at a specific case study, and then we'll land on how you can actually apply this in your work. Okay, let's dive right in, and we'll start by differentiating the diagnoses you're going to see. This is so much more than just a label in the DSM. It really points to fundamentally different lived experiences. Now, while I know you're all familiar with PTSD, it's absolutely essential to recognize that chronic, prolonged exposure, especially when it happens early in life, can lead to what we call C-PTSD. And look, this is not just a more intense version of PTSD. It fundamentally alters a person's core sense of self, their ability to trust, their capacity to form and maintain healthy relationships. Making this distinction is it's critical for your case conceptualization. Okay. So let's explore how trauma actually builds up inside a person. When you're listening to your clients, you're not just hearing a list of events. You're hearing a story that trauma has actively and often brutally rewritten.
This quote really gets to the heart of the matter. Trauma isn't just a memory that you file away. It's a filter. It literally changes how a person sees themselves, how they see others, how they see the world. Their entire personal narrative, the story of who they are, gets completely reshaped by that experience.
And this reshaping, it actually shows up in the very structure of your client's language. Research shows us that trauma narratives are often longer. They're packed with way more emotional and sensory details. You'll notice clients who seem stuck talking about the past far, far more than the present or the future. And pay close attention to the pronouns. A shift from I and me to they and them can signal a really profound sense of detachment. Listening for these markers is a powerful diagnostic tool.
Another critical internal variable is this concept right here: Coping Self-Efficacy, or CSE. Now, this isn't about what coping skills a person has in their toolbox, but rather their belief in their ability to use them effectively. That confidence is a powerful, powerful predictor of a client's trajectory after trauma. And this distinction, it directly frames our therapeutic goal, right? Clients with high CSE, they're more likely to engage in adaptive coping and actually experience post-traumatic growth. But those with low CSE, they often fall into these vicious cycles of avoidance, rumination, and substance use. So a huge part of our work is about building that client's CSE, empowering them to believe in their own resilience. You see, when trauma is chronic, especially during childhood, it doesn't just create difficult memories, it actually forges core beliefs. The self is seen as damaged, incompetent, weak. The world becomes a place that is fundamentally unsafe and judgmental. And then this deep, deep sense of self-blame takes root. These solidified beliefs can lead to what the research calls perceived burdensomeness and a lifetime of thwarted belongingness, which, as you know, are major risk factors for very poor outcomes. Okay, now we're going to zoom out from that internal world to see how a client's identity and their place in society can really affect their outcome, because no client ever exists in a vacuum. The data on this are pretty clear. Gender is a significant variable. For instance, in adolescence, females with high trauma severity often experience worse academic outcomes than their male peers. And if you look across the lifespan, women are nearly twice as likely to develop complex PTSD. This demands sensitivity in our assessment and our treatment planning. A one-size-fits-all approach just doesn't work. It's not effective. This number is stark, and you need to have it seared into your clinical mind: 1.89. It represents the pooled odds ratio for suicide attempts among survivors of early life sexual abuse. What that means is these survivors are almost twice as likely to attempt suicide. This is a critical risk factor that we must always screen for.
We also have a huge responsibility to practice with cultural humility. Systemic factors are part of the client's lived experience of trauma. Discrepancies in educational resources can compound the academic fallout of trauma for Black and Hispanic students. A person's cultural identity shapes everything, from their social support networks to the very meaning they make of their trauma. Having open, direct dialogue about systemic disadvantage isn't being political. It's being validating. It is good clinical practice.
Now, to see how all these variables come together in the real world, let's just examine a specific population that experiences both acute and chronic stress as part of their job: law enforcement officers.
This quote just perfectly captures the conflict, doesn't it? There's this professional expectation of stoicism, of being impenetrable. But underneath that armor is a human being who's subject to the immense psychological weight of their work. And over time, that armor can, and it does, fracture.
And, well, the numbers bear this out. The rate of PTSD in police officers is around 13%. That is a full 4 times higher than in the general population. That statistic alone really underscores the unique and intense psychological toll of this profession.
So when you assess an officer, you have to look beyond the single critical incident. Yes, of course, there's the acute traumatic exposure, the life-threatening calls, the graphic scenes. But there are also the chronic, grinding organizational stressors, things like excessive workloads, relentless negative media scrutiny, and a feeling that the very system they work for is failing. Both of these contribute to the fracturing of that armor.
And what happens when that armor fractures and the trauma goes unprocessed? Well, maladaptive coping often rushes right in to fill the void. This data point is so telling. In one study, 88% of officer arrests were alcohol-related. This just reveals a common and very dangerous consequence of turning to external methods to manage that internal pain.
Okay, so we've explored all these variables. How do we synthesize this information into our actual clinical work? Let's outline a practical, actionable approach you can start using in your practicum right away. I want you to use this 5-step framework as your guide. So first, assess beyond the event. Is this PTSD, or does it maybe look more like C-PTSD? Second, listen deeply to the narrative. Look for clues about their core beliefs. Third, evaluate their coping self-efficacy. Fourth, always consider systemic factors like race and gender. And finally, number 5, explore their context. What world are they living and working in? This approach, it ensures a truly comprehensive, client-centered assessment.
This really is the essence of trauma-informed care. It means moving past the diagnosis on a chart to truly understand the whole person and the unique constellation of variables that defines their experience. Our ultimate goal is not just to treat a disorder, it's to see and validate the entire person sitting across from us.
And so I'll leave you with that question to carry into your clinical work this week. Beyond the diagnosis, how will you make sure you are seeing the whole person? Class dismissed.